nursing staff, whether you're an intern, a medical officer, whether you're a registrar or a trainee, or whether you're a seasoned professional or a seasoned campaigner in the wards, these lectures have something to benefit everybody. And even if you're just here for the jokes as well. Okay, so the format of each video, we're going to kick off with some relevant terms and definitions, then followed by a discussion of a diagnostic framework. What, pray tell, is a diagnostic framework? This is a list of diagnoses which can explain the presence of a specific symptom, physical exam finding, or diagnostic test abnormality, organized into discrete categories. Let me walk you through some examples. Okay, so for instance, most commonly diagnostic frameworks are based on organ system, like we see the causes of chest pain here, right? Divided into cardiovascular, pulmonary, GI, muscular, skeletal, and miscellaneous. However, for some systems, alternative organizational schemes might actually be more appropriate, such as when we talk about pathobiological mechanisms of edema, for instance, all right? Or, as we will talk today, about an anatomical stratification, which works well, particularly for abdominal pain, which we will be talking about today. Now, diagnostic frameworks help us remember diagnoses, which we should always consider in a patient, which may or may not eventually make their way into our differential diagnosis for that particular patient. So as a general rule, diagnostic frameworks should be relatively comprehensive, but for the purposes of this particular series, we're going to keep them limited to including only those diagnoses which are either number one, common in practice, number two, commonly tested, or number three, particularly dangerous if you miss it. After presenting a diagnostic framework for a specific symptom, we will then move on to a diagnostic algorithm. This algorithm will be the pragmatic approach to making the correct diagnosis in the patient presenting with that symptom. Next may come a few clinical pearls regarding diagnostic strategic thinking, and we will then end each talk with a summary of doggy bag of key takeaway points. All right. So unlike many other similar resources you may encounter on the web or in the library, the approaches I will present here will represent how physicians think about problems in real life. These approaches are informed by textbooks, clinical practice guidelines, and literature, but they also incorporate my own personal experience and observations as a practicing physician in the state. Now, as they are presented at the level of a healthcare professional in training, the algorithms will cover most, but not every conceivable situation. So I'm not going to mention particularly esoteric diseases, and if a certain diagnostic test is really performed in practice, we're not going to talk about it, irrespective of how classic it may be or its historical importance. My goal here, ladies and gentlemen, is to be accurate, practical, and relatively concise. So I hope we're going to find that helpful. So enough about that, all that mumbo jumbo. So far, guys, remember that there are 32. There are 32 topics in this series, of which we are now on number 8. Number 8 is acute abdominal pain. So far, we've covered quite a bit of ground. We discussed syncope, shock, palpitations, chest pain, acute dyspnea, hemoptysis, and cough, right? So today is acute abdominal pain. Dr. Mawela, this means we are 21% the way to having the brain of a physician. Okay, and of course, I love my, thank you for that. I love my humor. I regard myself as a sit-down comedian, not a stand-up. Although after the erectile dysfunction workshop, maybe that may change. So whenever you see this guy, that's a humor slide, right? So speaking about that, here's our first humor slide. I actually, when I was researching the topic, I went to the library to check out a medical book on abdominal pain. But when I got it home, I found that someone had ripped out the appendix. All right. Okay, let's get started, guys. Just to throw some context into the whole situation, let's talk about a clinical case. Okay, imagine that you are working in casualty or emergency care. You got a 52-year-old man who comes to you with acute onset abdominal pain that he says woke him up from sleep. He has a history of paroxysmal atrial fibrillation, but has had no recent episodes of AF on remote monitoring. Yes, this gentleman has access to remote monitoring. He has no prior history of abdominal surgery. His pain, he says, is 7 out of 10 in severity and comes on in what he describes as intense waves. So it comes and goes, very colicky in nature. He has vomited twice, and each time his pain improved somewhat for a few moments afterwards and then came back. It improved and then it came back. He is afebrile with a heart rate of 126 beats per minute, so he's tachycardic. That is confirmed to be a sinus tachy on ECG, so not a sinus arrhythmia. This is sinus tachycardia. He is afebrile. His abdominal, or rather, his abdomen is tender and distended. He has high-pitched so-called musical bowel sounds. CT is shown here. All right. So this gentleman has no evidence of gallstones or ductal dilatation on a right upper quadrant ultrasound. Pancreas appears normal, but we can't really see the pancreas in this particular cut, but pancreas did appear normal. So which of the following is the most likely cause of these symptoms? Is it, I mean, given the presentation thus far, right, and given the imaging, right? Is it A, acute mesenteric ischemia? Is it B, acute cholecystitis? Is it C, acute pancreatitis? Is it D, SBO, which is small bowel obstruction? Or is it E, viral gastroenteritis? So if this looks a bit puzzling, fear not, because at the end of the session, hopefully we will be able to answer this question confidently. All right, so as we know, today we're talking about acute abdominal pain. Now, diagnostic frameworks for acute abdominal pain are either based on anatomical region or by organ system, right? You can either go either way. With the former, which is anatomical region, probably being a bit more common. Now, if using the region to organize a list of possible diagnoses, the abdomen can be divided into 4 quadrants with the umbilicus at the center. However, it's probably even better, instead of 4 regions, to go 9 regions, right? So the first way is to go, okay, 4 regions, that's very well and good, but it's better to separate it into 9 regions, okay? So these 9 regions, I'm sure all of us are familiar with from our time in general surgery. Okay, so there's right and left upper quadrant with the epigastrium in the middle. Then there's right and left flank with the periumbilical area in the middle. Then there's the right lower quadrant and the left lower quadrant with these suprapubic area in the middle. All right, so when trying to consider what disease might cause pain located in a certain region, the simple principle is to consider what structure lies within that particular region. So if you pain in the right upper quadrant, you're probably thinking, okay, liver, biliary pathology. Whereas pain in the left upper quadrant could be from the spleen. Now, I'm going to go through specific etiologies while traveling around the abdomen, starting in the epigastric region. All right. So let's start with that. Okay, so here we're just talking about, yeah, we said that pain in the right upper quadrant could be liver or gallbladder pathology, right? So, just finding my bearings. Yeah, there we go. So pain located here in the epigastrium could be from GERD, which is gastroesophageal reflux disease, could be gastritis, peptic ulcer disease, gastroparesis, most commonly a sequelae of long-standing diabetes because of autonomic neuropathy, right? Pancreatitis, and occasionally you can have referred pain from an acute coronary syndrome, right? Pain in the left upper quadrant can be, for instance, from a splenic infarct, splenic abscess, or splenic rupture. A subdiaphragmatic abscess could even be referred pain from a left lower lobe pneumonia, right? Now, pain in either one of the flanks, right, can be due to nephrithiasis, which is the term we use for kidney stones, excuse me, pyelonephritis, which is an infection of the kidney, or it could be a perinephric abscess or a perinephric collection, which is simply an abscess adjacent to the kidney, right? Periumbilical pain is most commonly from simple viral gastroenteritis, but could also be from small. Let's see, I've got a frog in my throat. Excuse me. Let me just drink some water. Yeah, okay, there we go. So we said periumbilical pain most commonly from simple viral gastroenteritis, but could also be from small bowel obstruction, mesenteric ischemia, which is like angina of the gut, or it could be due to the dreaded Untersuchenbluten. Untersuchenbluten is a German word which means really thought about, right? Ruptured triple A. Nobody thinks about a ruptured triple A, but it's there. Okay. Then triple A stands for aortic abdominal aneurysm, right? Then suprapubic pain can be from cystitis or a simple urinary tract infection. Could be from pelvic inflammatory disease, which is a severe complication of a sexually transmitted infection seen in women, or it could be the dreaded ectopic pregnancy, which basically occurs whenever an embryo is implanted somewhere other than the uterus, a condition which results in a non-viable pregnancy and is life-threatening to the mom. Okay. Now, pain in the right and left lower quadrants have very similar pathologies, including ovarian and testicular torsion, a ruptured ovarian cyst, a tubal ovarian abscess, and ectopic pregnancy. Now, two differences between the right and left lower quadrants is that appendicitis pain is located in the right lower quadrant only, unless the patient has a very unusual anatomic variation in the position of the intra-abdominal organs. And diverticulitis tends to be more common on the left than on the right. Okay. Last is the right upper quadrant. Yes, I left the right upper quadrant blank there, which I think of as somewhat of a more distinctive entity than the others, on account of particularly complex and numerous potential liver and biliary pathologies which live there. So let's take a look at this region more closely. So we're going to zoom in, we're going to hone into the right upper quadrant a bit, right? Okay, before we get there, this is a fun cartoon from midcomic.com. A big thank you to Mr. Jorge Muniz for the use of these cartoons. So ectopic pregnancy, essentially, we said, is implantation anywhere outside the uterus, right? Manifests with abdominal pain, abnormal vaginal bleeding. Implantation occurs outside the uterus. The most common site is the beloved fallopian tube, and it manifests with an adnexal mass, okay? Patients present with syncope or hemorrhagic shock, and that can occur when there's rupture. Okay, ideally you want to go surgical, right? And here we have the transvaginal ultrasound probe, which says, serum BCG is 2000, but I'm not picking up anything. And the dolphin is there saying, something's fishy. Well, I'll leave you to figure out why it's saying fishy, right? Okay, so here we are. Now we can broadly partition. Thank you for those emojicons, guys. So we can broadly partition etiologies of right upper quadrant pain into those from the liver, those from the biliary system, and other. This is a very useful way to stratify right upper quadrant pain, okay? So etiologies of hepatic pain can be divided broadly into infectious and non-infectious. Under infectious is acute viral hepatitis, okay, and liver abscess. Non-infectious causes include alcohol and medication-induced hepatitis, hepatic congestion from heart failure, and Budd-Chiari syndrome, which is caused by obstruction of the hepatic vein. Okay. Biliary pathologies also can be divided the same way: infectious, non-infectious. Under infectious are acute cholecystitis, which is essentially inflammation and infection of the gallbladder. And then we have its cousin, acute cholangitis, right, which is inflammation and infection of the common bile duct. Relevant non-infectious pathologies of the gallbladder include simple gallstones, which lead to a condition known as biliary colic. And then we have choledocholithiasis, quite a mouthful, which essentially means a gallstone trapped within or actively passing through the common bile duct. Lastly, any other causes of right upper quadrant pain could represent referred pain from a right lower lobe pneumonia, or it could be a right-sided subdiaphragmatic abscess. Okay. Okay. Dr. Spoon is saying you've got irritable bowel syndrome. Okay. There are some etiologies of acute abdominal pain that can be either generalized or poorly localized, including inflammatory bowel disease. And we know the two brothers of inflammatory bowel disease are ulcerative colitis and Crohn's disease. Okay. Infectious colitis, for instance, Clostridium difficile, which is antibiotic-associated diarrhea. Spontaneous bacterial peritonitis, often occurring in patients who have cirrhosis. Okay. Secondary bacterial peritonitis or secondary peritonitis, typically occurring from bowel perforation. And everybody's favorite, hyperglycemia with acidosis, and ketonuria equals diabetic ketoacidosis. Is one of the causes of a high NIM gap. Metabolic acidosis, right? We've discussed this in times past. Now, some relatively rare but nevertheless important causes of acute abdominal pain are adrenal insufficiency, acute intermittent porphyria, and abdominal migraine. Yes, abdominal migraine. Angioedema, which sometimes surprises people, since we are more familiar with angioedema in the context of swelling of the mucosa of the face and throat. But the very same pathobiology can occur in the gut. Colonic pseudoobstruction, which some people call Ogilvie syndrome. Herpes zoster, in which the pain can occasionally proceed the onset of a unilateral vesicular rash by a few days, and rectus sheath hematoma. Okay. Let's bring back our beloved abdomen. Here's the abdominal picture to make a few more points about location. So some etiologies of abdominal pain have somewhat more common patterns of radiation, right? Radiation. For example, pyelonephritis, our good friend here, typically radiates around the flank to the lateral back, whereas nephrolithiasis, our good friend kidney stones, radiates from to the groin. So we classically call that loin to groin pain. Hepatic and biliary pathology often radiates to the right shoulder, and pain from pancreatitis and a triple A, which is abdominal aortic aneurysm, can radiate straight backwards. Okay. Now, when it comes specifically to appendicitis, there is a classic migratory pattern to the pain. So early appendicitis, which triggers just visceral pain fibers, is first felt not in the right lower quadrant, but rather in the periumbilical area, where its actual location is kind of vague and not yet associated with tenderness, right? That's the early phase. In the next phase, as the peritoneum overlying the appendix becomes inflamed, the pain is now felt more in the right lower quadrant as demonstrated and is associated with significant tenderness. And later on, if the appendicitis is not identified and treated in a timely fashion, perforation may ensue, leading to generalized pain along with peritoneal signs from secondary peritonitis. Okay. Now, guys, I just want to mention that visceral pain fibers localize very poorly compared to somatic fibers, which innervate the peritoneum. So as a consequence, despite the specific anatomical framework we reviewed earlier, pain does not always map neatly into specific abdominal quadrants or regions. For instance, visceral pain from the foregut, as shown from foregut structures, is most commonly perceived in the epigastric region, but can be found in either the right or left upper quadrants or even near the umbilicus. Now, pain from midgut structures, midgut structures, can extend into the epigastrium and even the suprapubic areas. Hindgut structures can lead to pain throughout half the abdomen. Pain from the genitourinary system and reproductive systems can be widespread, and even pain from the liver and biliary system can extend outside the right upper quadrants, okay? So pain doesn't always map out neatly as described in the textbooks, okay? Okay, here we have a little boy saying, "Are you in pain?" The girl says, "No, the pain is in me. I am not in the pain." Semantics. Okay, now I'll shift to discussing the step-by-step evaluation of abdominal pain, starting, from the history. Because, the basic tenets of clinical medicine is number one, history taking, number two, physical examination, number three, investigation, number four is treatment, all right? So you got to take a good history, regardless of whatever presentation you have, provided it's not a critical emergency situation. You got to get back to the basics. History taking is what we're talking about. So now I'll shift to discussing the step-by-step evaluation of abdominal pain. We're kicking off with the history, right? Now, one of the most important questions is the chronology of the pain. Okay, for example, what we're talking about, it's acuity of onset. An extremely abrupt onset suggests bowel perforation or a vascular catastrophe, including intra-abdominal thromboembolism, especially on the backdrop of somebody who has atrial fibrillation, okay? It could be a ruptured AAA, it could be ovarian or testicular torsion, right? So acuity is very important. Next thing we want to know, okay, sorry, let's go back there. How long has the pain been present for? And whether it is episodic or continuous. So as a general rule, epigastric pain suggests a less imminently dangerous pathology, such as biliary colic, peptic ulcer disease, gastroesophageal reflux disease, chronic mesenteric ischemia, or gastroparesis. But this rule is far from perfect, since intermittent epigastric pain could be in a typical presentation of somebody who has acute coronary syndrome. Okay, so as we just viewed or reviewed the location, the radiation is helpful at narrowing down diagnostic possibilities. Now, determine what the exacerbating factors are. For instance, pain related in any way to food intake suggests an upper GI, pancreatic, or biliary pathology. You want to ask about the presence of associated symptoms. And here we're talking about things like nausea and vomiting, diarrhea, constipation, evidence of GI bleed. So is the hematemesis, are there melena stools, lack of flatus or passing gas, fever, jaundice, dysuria, hematuria. Obviously, you want to take a past medical history and surgical history and a proper full gynecological history as well. Medication history, sexual history for sexually transmitted infections or risk factors for STIs, substance use history, okay, particularly alcohol, blame it on the alcohol, travel history, and general exposure history, example, contaminated food or water. All right. All these things are important, guys, in the history. So the next thing that follows is your vital signs, obvious, right? Vital signs. And a focused physical exam should, of course, include a thorough abdominal examination. And if any type of reproductive pathology is on the differential for the female patient, you want to do a pelvic exam, do a PV, do a speculum exam if indicated. Now, since cardiac and pulmonary disease can refer to the upper abdomen, those exams should be performed as well. Okay. You may notice here that I have not listed a rectal exam. That's because a rectal examination is generally not indicated unless anorectal disease is suspected, specifically. However, in the context of a GI bleed, if you want to check for melena stools, it's probably a good idea to do a rectal exam, right? What about labs? Now, key labs in the workup of acute abdominal pain includes a full blood count, liver function tests, a full metabolic panel, and a lipase. The last of which is specifically to help identify our beloved pancreatitis. Now, historically, another test called amylase was used, frequently ordered in this presentation, but amylase is relatively non-specific and does not contribute really any useful information because the differential for hyperamylasemia is very, very broad. Okay. Other frequently considered tests, if the patient is a woman of childbearing age, you want to get a urine HCG, which is human chorionic gonadotropin, right? That's a preg test to screen for pregnancy. Even if she says, Doc, I am not sexually active, do not trust that cardinal line. You want to do a pregnancy test. Patients are sometimes not forthcoming, and an ectopic pregnancy is not a diagnosis you or your patient can afford to miss. Okay. If acute bowel ischemia is suspected, an elevated lactate will be consistent with bowel infarction, right? Now, unless your patient is young and healthy and without cardiovascular risk factors, it's always prudent to do a troponin level and an ECG to rule out acute coronary syndrome because we spoke about the radiation of the pain, which could manifest with abdominal pain, right? In the context of ACS. Now, if the pain is upper abdominal or if the patient has concurrent pulmonary symptoms, you want to get yourself a chest X-ray. If the patient reports either, dysuria or hematuria, check a urine dipstick, plus or minus urine culture, depending on your suspicion for a urinary tract infection. Now, there are numerous indications for either a CT or CT of the abdomen or ultrasound or really some other kind of imaging modality. While as a general rule, clinicians often over rely on imaging in most circumstances, but in my experience, acute abdominal pain is not one of them, right? So at this point in our lectures, usually I present a diagnostic algorithm that one could follow to arrive at the single most likely diagnosis. But with acute abdominal pain, there's just too many etiologies to reasonably include in one algorithm, right? Oh, look, we have a joke. Is there any kind of cake you don't like? Yes, stomach cake. I mean, stomach cake. Once a gentleman went to his GP and the GP said, what brings you in today? And the guy said, the ambulance. No, I'm joking. He said, no, doc, every time I eat birthday cake, I don't know, man, I just get this pain in my tummy. Yeah. And the doctor told him, try removing the candles first. Oh, I got another one as well, but I think I hold myself back with the jokes sometimes. Okay. Yeah. So we're going to review a handful of what I call illness scripts for some of the most common diagnoses, which we will compare. And we're going to contrast typical features. Okay. So we talk about typical historical features. We talk about risk factors, what you're going to find on examination, and relevant diagnostic tests. Okay, this is the way we're going to stratify a couple of the causes. I'm not going to go through everything. We're just going to go through the most common etiologies. Okay, now we're starting with right upper quadrant pain. Okay, first up, we're going to compare peptic ulcer disease versus gastroenteritis versus small bowel obstruction versus appendicitis versus pancreatitis. Those are our heavy hitters when it comes to the right upper quadrant. Okay. So in peptic ulcer disease, what can we say? The pain is epigastric. Occasionally, it radiates through to the back. It may be triggered by eating, and more eating. There is occasionally associated nausea and vomiting and overt signs of a GI bleed, like melena, but they are usually absent. The risk factors include non-steroidal anti-inflammatory drugs. So the patient who has chronic pain and he's taking all the Brufen and he's taking the naproxen and he's taking the mefenamic acid and he's taking all that stuff, right? And Helicobacter pylori infection, all right? Now, physical exam can show a mild to moderate epigastric tenderness. If there are peritoneal signs present, the ulcer has likely puffed. Watch out for a puffed ulcer, and that patient needs a surgeon, all right? Routine blood tests are usually unremarkable unless the patient has very significant bleeding. Peptic ulcer disease is diagnosed how? Via upper endoscopy, no? Which should be supplemented with testing for Helicobacter pylori. So we have certain modalities, you have urease, breath test, etc. But ideally, you want to see that ulcer. You want to get in there, do a scope, and look at your ulcer. And that cinches the diagnosis. Okay, what about viral, or rather not viral, what about gastroenteritis? Gastroenteritis here, the pain on history is typically periumbilical. It's often crampy and associated with nausea, vomiting, diarrhea. In most cases, there aren't really significant risk factors outside of an outbreak. Okay. The examination will show you mild to moderate periumbilical or generalized tenderness, but no rigidity, no peritoneal signs. No rigidity, no peritoneal signs. Fever and signs of dehydration are common, all right? The only typical abnormal blood test here is going to be an elevated white count. Diagnosis is simply clinical, not requiring any imaging, no endoscopy. So in just the last several years, some medical centers have begun employing stool PCR panels, particularly available in private, for some patients presenting with diarrhea in order to ascertain the specific etiological pathogen. So like gastroenteritis, uh, sorry, yeah. So some places do use stool PCR, but it's not routinely done. One exception is if you are considering Clostridium difficile, in which case you're going to send that stool off and look for toxin A and toxin B. That, of course, is in the context of somebody whom you think has antibiotic-associated diarrhea. So they have been exposed to healthcare somewhat recently and are presenting with refractory persistent diarrhea. Okay. What about SBO? What is SBO? Small bowel obstruction. So like gastroenteritis, the pain from a small bowel obstruction is typically periumbilical and cramping in nature. It's associated with nausea, vomiting, abdominal distension, and the absence of flatus. So the patient says they can't fart. Risk factors for a small bowel obstruction includes prior abdominal or pelvic surgery, hernias, foreign body ingestion, inflammatory bowel disease, and an intestinal tumor. The exam usually shows, abdominal distension. There may be very high pitched. This is what they call high pitched sickle bowel sounds. There may also be signs of dehydration, and peritoneal signs suggest perforation or infarction. Okay. So even though a small bowel obstruction can usually be diagnosed on history and exam alone, these patients should ideally all get a CT scan to identify the location of the obstruction and to search for potential etiologies. If for some reason CT is not available wherever you're at, plain abdominal films are a reasonable alternative to definitively confirm the diagnosis, in which case an upright film and supine abdominal films should be ordered plus or minus upright chest X-ray. Why are you doing a chest X-ray? You're looking for the presence of free air under the diaphragm, which indicates that you probably have a perforation on your hands. Okay. Appendicitis, as already discussed, is pain from appendicitis is classically present in the right lower quadrant, but often begins in the periumbilical region, like we discussed. Nausea, vomiting, and anorexia usually follow the onset of pain rather than the other way around. Now, if there is severe generalized pain, perforation is likely. There are no major risk factors for appendicitis. On exam, the most notable finding is tenderness at a specific location, which everybody knows as McBurney's Point. What is McBurney's Point? It is located 1/3 of the distance along an imaginary line from the anterior superior iliac spine to the umbilicus. There are some other classic, but somewhat less discussed findings. Some of us may be familiar with Rovsing sign. So in Rovsing sign, you're palpating in the left lower quadrant, and the pain is perceived by the patient in the right lower quadrant when you're pressing the left lower quadrant, right? Psoas sign is when you basically place your hand above the patient's right knee and you ask them to lift up the knee. And because of the contraction of the psoas muscle and the friction with the inflamed appendix, the patient perceives pain in the right lower quadrant. Obturator sign is basically where you're flexing the hip and then you internally and externally rotate the leg, and the pain is perceived once again in the right lower quadrant. Similar pathobiology, because of inflammation of the appendix, it rubs against the obturator muscle when you're doing this, and that causes pain, right? So, but those signs lack specificity, all right? But they are described in the textbooks, which is why I just mentioned them here. Patients are often febrile, and often again, peritonitis is going to suggest that you have a perforation on your hands. Those patients need the surgeon, okay? Significant labs include high white count and an elevated C-reactive protein, while an elevated CRP would be expected in some other abdominal diseases, such as peritonitis and acute cholecystitis. For some reason, it's more discussed as a feature of appendicitis. Specifically, there is a clinical prediction rule, which we call the Alvarado score. Not avocado, Alvarado score, which assigns patients to various historical exam and lab features to give you an overall probability of the diagnosis. So any patient with suspected appendicitis should undergo imaging, which can be either CT or ultrasound, the choice of which is institution, clinician, and situation dependent, depending on wherever you are in the country. Okay. Okay, pancreatitis, the kingpin pancreatitis, in which patients present with epigastric pain radiating to the back or around to the back. That's exacerbated by eating and relieved by sitting and leaning forward. It's usually associated with nausea and vomiting. Now, dyspnea is more commonly an associated symptom in pancreatitis than with the other diagnoses in this chart. So if you see dyspnea, abdominal pain, you want to think about pancreatitis. Risk factors or etiologies for pancreatitis include blame it on the alcohol and gallstones, which together account for the overwhelming majority of etiologies. Less common things include ERCP, hypertriglyceridemia, and a variety of medications. I'm sure all of us are familiar with the beautiful acronym from Oxford Handbook of Clinical Medicine, GET SMASHED! G is for gallstones, E is for ethanol, T is for trauma, S is for steroids, M is for mumps, A is for anti-nuclear factor in the context of someone who has an autoimmune condition. All right. The S is for scorpion venom. Oh dear. H is for hypertriglyceridemia, E is for post-ERCP, and D is for drugs, and more drugs. On examination, severe cases can present with shock and periumbilical or flank ecchymoses, suggest hemorrhage secondary to pancreatic necrosis, a particularly worrisome sign. So some of us may be familiar. I mean, Tally and O'Connor speaks about gray Turner sign, Cullen sign, Fox's sign. So gray Turner sign is basically discoloration of the flanks because of intra or retroperitoneal hemorrhage, which is going out and affecting that area. Cullen sign is the same discoloration or ecchymosis periumbilically. Fox's sign is the same thing, which happens at the inguinal ligament. Okay, all of these are significant of necrotizing pancreatitis with retroperitoneal or intraperitoneal hemorrhage. The most notable abnormal lab is a very, very elevated lipase. Lipase is crazy high, typically more than 3 times the upper limit of normal. Now, while a CT scan is not considered necessary for the diagnosis, you can assess for complications here and can help identify gallstones in the pancreatic duct as a potential causative factor. And remember that pancreatitis can cause a whole truckload of complications, guys. You can have necrotizing pancreatitis, hemorrhagic pancreatitis, pancreatic pseudocyst, you can have splenic vein thrombus, you can have overwhelming sepsis, you can have multi-organ dysfunction, you can have death. Okay. Okay, this is a nice way of thinking about Helicobacter pylori. There's a naughty guy here. He's a common precursor for gastritis and peptic ulcers. It's a risk factor for gastric carcinoma. It's a curved gram-negative rod. He's busy peeing in here because he's producing urease, which produces ammonia that damages your gastric mucosa. Ammonia also neutralizes acidic pH, which allows the organism to live in the stomach. Treatment is with your triple therapy, omeprazole, clarithromycin, amoxicillin. It's dual antibiotics with a PPI. So we say goodbye to Helicobacter. Appendicitis, okay, we spoke about this. Rough-Singh sign, obturator, psoriasis. We already touched on that. We speak about tenderness, like McBurney's point, and we spoke about this, right? The appendix, it says, it started with periumbilical pain, and then it moved to my right lower quadrant. It's usually caused by feculates or by lymphoid hyperplasia, right? If God were to give us one part of the body, which probably serves little to no function, and which is fraught with problems, that would be the appendix. God, why did you give us an appendix? It only causes problems, mostly, okay? The doctor tells this patient, I've got to the bottom of your sharp stomach pain. Your underpants are too small. Probably, I think that patient could pass for me. I think my underpants are also getting a bit too small. Um, okay, now let's quickly run through four particularly important causes of right upper quadrant pain, right? So I just want to touch here about biliary colic, acute cholecystitis, acute cholangitis, and acute hepatitis. So we haven't mentioned these four. Let's quickly review this because it's already 7:15. So in biliary colic, this is caused by gallstones now within the gallbladder, and the pain is typically kind of episodic, lasting 30 minutes to several hours. It's often triggered by eating, because when you eat, some of the food you eat contains fat, and fat is going to release CCK-PZ, cholecystocinin pancreasimine, which then causes contraction of the gallbladder, right? So whenever you eat, fat comes down into the small bowel. You have triggering of this. But if you got a gallstone there, you're going to have pain, right? Now, there is no associated jaundice. Risk factors include female sex, pregnancy, obesity, rapid weight loss, and diabetes. We speak about the 5 Fs, which are risk factors for gallstones, okay? You know the story, fertile, female, over 40, all of that, okay? Now, the physical exam is usually unremarkable as a routine blood test. Right upper quadrant ultrasound is going to show us gallstones and help to clinch the diagnosis, but this is a non-emergent study if the clinical presentation is classic, okay? That's biliary colic. Now, the pain in acute cholecystitis is progressive over many hours, nausea and vomiting common, and since the common bile duct is not involved, there is no jaundice. The most notable risk factor for acute cholecystitis is the known presence of pre-existing gallstones. Okay? The patient tells you, listen, doc, somebody told me I had gallstones before. Okay, no surprise. On exam, patients are often febrile. The classic finding is an increase in right upper quadrant tenderness on inspiration when the diaphragm descends, pushing the liver and gallbladder into the examiner's stationary hands. This is known as the infamous Murphy's sign. Murphy's sign. Not Murphy from The Good Doctor now, although probably he might have discovered the sign, I'm not sure. There's also something called the sonographic Murphy's sign, in which pain is worse with inspiration when the pressure is applied to the right upper quadrant with an ultrasound probe at the exact location of the gallbladder, since the examiner can directly see it on the screen. Now, the sonographic Murphy's is thought to be somewhat more specific than the classic clinical Murphy's, right? Routine lab tests usually reveal an elevated white count. A normal or near normal liver function test. Definitive diagnosis can usually be made with a right upper quadrant ultrasound, and that is that. What about acute cholangitis? The pain here is similar to acute cholecystitis, and nausea and vomiting are also common. However, jaundice also occurs, right? Risk factors for acute cholangitis include benign biliary strictures and malignant obstruction of the biliary system, including pancreatic tumors, especially the infamous head of pancreas tumor. As a very general rule, patients often appear more ill than in other common causes of right upper quadrant pain, but this is less often the case among the elderly and among those who are taking immunosuppressive medications. Common test findings include a high white count, a high bilirubin, which is predominantly direct or what we call conjugated fraction of bilirubin, a high alkaline phosphatase, which is a ductal enzyme, and they may or may not be mild or moderate elevation of our beloved transaminases, aspartate aminotransferase, alanine aminotransferase, ALT, AST. And if after the history exam and blood test, the pretest probability of cholangitis is high, one probably should proceed to an ERCP. ERCP stands for endoscopic retrograde cholangiopancreatography. Otherwise, consider a right upper quadrant ultrasound. And the last diagnosis, everybody's favorite, acute hepatitis, which is acute infection and or inflammation of the liver. ICBD, I think that's the word for liver, right? The symptoms of acute hepatitis can be similar to those of acute cholangitis, though in my experience, the onset is slightly more prolonged. Now, risk factors, or more appropriately, etiologies here include hepatitis viruses, A through E, particularly hepatitis A, alcohol is common, eh? Mm. Yes, alcohol and paracetamol toxicity and autoimmune hepatitis. Now, there are many other causes of acute hepatitis, but these four cover the overwhelming majority in Western populations, okay? On examination, fever is sometimes present, and there can be a variety of findings related to liver dysfunction, depending on the severity and the acuity of presentation, right? Labs are going to include high white count, especially extremely elevated transaminases, often over 1,000, whopping high ALT, AST, high alkaline phosphatase, high bilirubin, high bilirubin, right? Classically, with the direct and indirect being roughly equal. Now, this is different from what we spoke about under acute cholangitis, where there's a predominant conjugated hyperbilirubinemia. Here we're saying, okay, direct and indirect fractions roughly equal, and we have elevated international normalized ratio. Okay. Other tests you should probably order include hepatitis viral serologies, okay, and paracetamol level, though a single number is impossible to interpret in the absence of a known time of acute blood ingestion. Because we use the Rumac nomogram and we talk about that stuff, okay? Also, if another etiology of the hepatitis has not been clearly established, autoantibodies for autoimmune hepatitis are reasonable to order. And those include your anti-nuclear factor, your anti-liver kidney microsomal antibody, your anti-smooth muscle antibody. And if you're thinking about PBC, you probably want to get an anti-mitochondrial antibody as well. Okay, so there's acute cholangitis. The thermometer is saying, you're so hot. That's what we call Charcot's triad. Jaundice, fever, right upper quadrant pain. Jaundice, fever, right upper quadrant pain is Charcot's triad. Right. So that is significant for cholangitis. If you have, on top of that, you have hypotension and altered mentation, that is referred to as Reynolds pentad. Reynolds pentad speaks to septicemia secondary to acute cholangitis. Okay. Abdominal aortic aneurysm, the Unterseelenbluten that nobody really thinks about, right? This is most commonly caused by atherosclerosis, and the magic number is 5.5 centimeters, okay? Surgical repair is indicated for a AAA, which is above 5.5 centimeters in diameter, or any size which has demonstrated rapid growth on serial monitoring. Risk factors, the usual story, male, smoking, hypertension, advanced age, okay? Remember, the magic number is 5.5 centimeters. Okay, just a couple of things, guys. We're rounding up now. When discussing acute abdominal pain, it's common to hear the term surgical abdomen. Now, use of this term implies that the underlying etiology requires an emergent evaluation by a surgeon. Now, specific exam characteristics that are consistent with the surgical abdomen include rigidity, also known as involuntary guarding. So rigidity is simply involuntary guarding, which is the most concerning of the abdominal physical signs. Unusually severe tenderness to palpation, signs of peritonitis, known as the peritoneal signs, including rebound tenderness. Now, what is rebound tenderness? This is the finding that pain caused by slow abdominal pressure applied by the examiner's hands is not as severe as the pain caused by the quick release of the pressure. Okay? It includes a positive cough test in which pain is worsened by coughing, the so-called bed bump test, in which it is worsened by the examiner bumping the bed hard, which probably works better on a gurney or on a stretcher than a sturdy hospital bed, right? Or else you're just going to cause yourself an injury. Or the heel strike test, in which the pain is worsened by the examiner firmly striking the patient's heel. Aha, right? In the ambulatory patients, the heel strike test can be done by asking the patient to stand and jump in place and absent bowel sounds. It's one of the few places in medicine where you want to ask the patient to stand and start jumping. Let me tell you a quick joke. I'd start off a joke. Yeah. So, once there was a guy, who just went to the pharmacy and got his medications. And the doctor asked him, why are you shaking and gyrating like that after getting your medication? The guy said, well, see on the bottle, it says shake well before use. You mean shake the bottle. You don't actually shake. Shake it like a Polaroid picture. in the words of Ludicrous. Now, none of these findings in isolation necessarily indicates a surgical abdomen, but seeing multiple of them in a patient whose history is consistent with a possible surgical emergency would suggest this general situation. Also, guys, I want to point out, not every surgical emergency presents with a surgical abdomen, right? Specifically emergencies which are extraperitoneal. Now, which emergencies are extraperitoneal? Classic Untersehnenbluten ruptured aortic aneurysm will not give you peritoneal signs, okay? So the term surgical abdomen is sometimes used interchangeably with the term acute abdomen, not acute abdomen, acute abdomen, right? Because if you call the patient's abdomen acute, you might be facing a lawsuit, okay? Although some clinicians use the latter term more broadly to mean any patient with acute abdominal pain and any notable physical exam finding, irrespective of likely pathology, okay? Okay, this looks familiar. This is coming back now, coming full circle to our clinical case. So we had a 52-year-old gentleman. He's got paroxysmal atrial fibrillation. He comes into you now with no recent episodes of AF. He's coming with a history of abdominal surgery. Pain is 7 out of 10. Kind of colicky in nature. He vomits, it gets better, then it gets back. He vomits, gets better, then it gets worse. Vomits, sorry. He is afebrile with a heart rate of 126. He has a sinus tach on ECG, afebrile. His abdomen is tender and distended. He has high-pitched sickle bowel sounds. CC abdomen is shown here. Okay, so what are you going to do when they come for you? You're going to call bad boys? You're going to call the surgeon? What you going to do? What you going to do? The answer is, can I have a drum roll, please? Small bowel obstruction. Small bowel. Look at this dilated, distended loops of bowel here, guys. Anyway, so what's the story? Why is it small bowel obstruction? Because of his symptoms. He gave you classic symptoms, right? He says, colicky pain, he vomits, it gets better, then it gets worse. Okay, he's not passing flatus. Exam findings we found, and the presence of air fluid levels and dilated small bowel loops on CT scan. Okay. And yes, there is a history of atrial fibrillation. However, in the vignette, we mentioned that his presentation is not consistent with acute mesenteric ischemia. And in fact, now he is in sinus rhythm, right? So at the moment, he is not in atrial fibrillation. So you can't say acute mesenteric ischemia, most likely. No. And there's no clear evidence of acute cholecystitis. There's no evidence of gallstone pancreatitis, because we said the pancreas is normal, isn't it? And neither is any ileus. Okay, so this is just for the surgeons in the house, or for those of us who love our surgery, looking at small and large bowel obstruction and how to tell the difference between these in terms of what's extrinsic, what's intrinsic, what's intraluminal. Okay, so in the small bowel, common is adhesions. Right? This guy had a history of previous surgery. Should always trigger off thoughts. Hey, maybe there's a interperitoneal adhesion which is driving small bowel obstruction. Right? Same with hernias. Right? Intussusception is a common intrinsic cause. When it comes to large bowel, adhesions are probably less common. But what is common is tumor, and more tumor. Neoplasia, large bowel, common. Diverticulitis, common. More common on the left than on the right. Okay. Feculates intraluminally. Okay. Okay, everybody. Thank you so much. It's been quite a roller coaster the last hour. But I just want to tell you, if you have a passion for internal medicine, as do I, and I'd like to think that most of us do have a passion for internal medicine, because I mean, there's about almost 600 of us on this particular webinar. I encourage you to enroll in the diploma in internal medicine. Now, so we have a coaching program for this. It's a preparatory program. Now, it's not for everybody who wants to write the exam. If you are seeing medical patients on your wards or in your clinic, you just want to sharpen your skill set. You want to sharpen your tools. This is for you. Okay. Now, for those of us who are planning to write, you have just over 2 months. Okay. So the preparatory program is geared towards those writing for the July intake. Okay, don't worry about that. And so far, we started in April. We've covered lots of ground, right? We've covered cardiology, we've covered endocrine, we've covered infectious disease, TB guidelines, we've covered nephrology. We're actually on our pharmacology week. And remember that our offering also includes 3 Saturday 8-hour workshops, right? We've done with the ECG workshop. We've got the chest X-ray workshop coming up and mechanical ventilation as well to follow in July, okay? So as you can see, there's a whole lot on offering here, not just for the exams, but with a view to real life interpretation, understanding, and management of patients, okay? It's not too late. It's not too late. You're welcome to join the program if you want to do so. Just check out the clinical care platform for how you will go about doing this, okay? And of course, for those who like YouTube, I have a YouTube channel with access to more than 400 videos covering a variety of topics in internal medicine. The channel is growing, and I would love to see you on the channel. And I thank you for those who are already subscribing and liking and sharing. I really, really appreciate everything. Okay, guys, this is your doggy bag now. Key takeaway points. Acute abdominal pain is one of the most common presenting symptoms to the emergency room and urgent care. There are many etiologies ranging in severity from benign and self-limited to imminently life-threatening. Etiologies are associated with specific locations of pain, but they don't always map as precisely to anatomical quadrants as references typically suggest. Once again, a case of textbooks doesn't always equate to reality. Okay? Abdominal pain can be referred from intrathoracic pathologies. And finally, the presence of rigidity, unusually severe tenderness to palpation, peritoneal signs, and absent bowel sounds are consistent with what we call a surgical abdomen, which usually requires emergent surgical consultation. Here are my references, everybody. Thank you so much for joining me. Dr. Mawela, over to you, brother.
Thank you, colleagues. Let's give Ryan, all the appreciation, lots of applause, celebrations, and hearts. Because, yeah, when we have a very, very busy physician committing their time for our own professional development, I think all we can do is to say thank you, Ryan, and we commit that the next patient we see tomorrow with abdominal pain, we will take proper history, we will examine and do some few tests and use the frameworks you have shared to care for this patient. And importantly, we will also share with colleagues and encourage them to attend. Remember, these sessions are free. You attend as many as you want. It's only the CPDs and administrative processes that require additional fees. Otherwise, we are here for you colleagues. Ryan, I saw a trending question, and before you
Yebo.
answer, shake first before you answer. Ne? And people want to know, why was there a dolphin with a scope? I think I saw 3 different people asking, so maybe it's something you need. I think in one of your slides, why was the dolphin?
Oh, dear.
Can't remember. Yeah, but somewhere there. That's why I'm
Yeah,
saying
the
before you
dolphin with the
answer,
scope.
shake first before use or before you answer. Thanks, Ryan. I can't remember the slide, but it's somewhere.
No, guys, man. Yeah, somewhere here, somewhere here.
Yeah.
Yeah, man. It's a it's a very fishy situation. Just leave it there. It's a very fishy situation. Uh,
Is that the answer after shake?
that's all I have to say, Let's go.
Uh,
Yeah, that's all I have to say.
okay.
I can't find it. Oh man, maybe it's earlier on, I think.
No, it's fine. So
Alrighty. But maybe we can answer some other questions so long.
yes, that's what I was saying. There
Yeah, yeah,
was a
yeah.
question.
There you go.
Okay, you want to reply with a scope. Was it this one?
No,
With a scope.
I think it's this one.
They will remind us, colleagues on the chat there as we try to find that. um, all right. Yeah, Anastasia, I think, are you the one who asked? Yes, well, Anastasia says yes, this one. So where's the scope? Okay.
Well,
Anyway.
no, but you know that this is ectopic pregnancy, right? So this is a transvaginal ultrasound. So this is
Yeah.
not the bowel, right? This is the vagina, and that's a transvaginal ultrasound thing. And now you get it. Now you understand that. Oh dear. Okay, let's move on.
Now I see. Now I see. All right.
Yeah.
Lavi Pule was asking why a liver abscess is classified as infectious. I don't know if you can have it if it's not infectious. But yeah, Ryan, is the first question you have?
Yeah. Yeah, sure, man. So, liver abscess, if you're looking at the primary etiologies, right, you get the
Uh,
pyogenic liver abscess and you get the amoebic liver abscess, okay? So both
sure.
of those are infectious in nature, right? So Entamoeba histolytica is a protozoan infection, and pyogenic will be caused by bacteria, right? And interestingly, Lesego, in amoebic
Mhm.
dysentery, it doesn't really coincide with diarrhea. One may think that, you get entamoeba causing diarrhea, which then tracks up into the liver, but actually there's no real temporal relationship between those two. So you can have a
Mm.
patient who doesn't have diarrhea coming in with right upper quadrant pain and fever, and you can diagnose immune liver abscess there. But yeah, I mean, it's an infectious etiology. So yeah.
Super, super. Lufimpu says he appreciated the presentation, but there's a request that if you can project the picture of the abdomen where you showed different quadrants with different etiology. I think you can
This one.
try and do that. In the meantime, yeah, I
Okay.
think it's that one. Mervin, would you like to ask your question live? Hi, Mervin. You have unmuted, but I can't hear you. Mervin? Oh, okay. Check your mic settings, and then we will come back to you. In the chat box, there was a comment about chest X-ray.
Mhm.
Let me see if I can still find it from Choco, and I think it was more about that when you were discussing when you spoke up. Can I just find the question so that I don't misread it? Uh,
No problem.
at
Because remember,
1904,
guys, chest X-ray is important.
yeah, he was saying I see you omitted abdominal X-ray. As an, it says, is it not an essential investigation, especially in ruptured visceral organs? I think that's the question. Yeah, it was 1904, but in the chat.
Okay. No,
Yeah, sure.
mhm. No, thank you, Dr. Chonko. I think at that particular point, I'm not really sure where I was or what pathology I was speaking to, right? But in the context of somebody who's peritonitic, okay, you want to do a chest X-ray to look for free air under the diaphragm, or you may miss a perforated viscus, okay? Abdominal X-rays, yeah, definitely you want to do it, but only
Mm,
if you're creating certain pathologies. You don't always have to get abdominal X-rays in everybody. Right? But in
mm,
someone who you think, okay, this patient's probably peritonitic, let me look for features of bowel obstruction. If the patient has features of, vomiting, the patient has a distended abdomen, the patient's in shock, abdominal X-ray is probably a good idea. You want to do both erect and supine abdominal films, all right? Yeah, so we don't always do it. Like in the patient who has run-of-the-mill diarrhea, who's presenting with abdominal cramping, non-specific issues, you don't have to get an abdominal X-ray, right?
mm,
So I
mm.
think it's very context specific, Chonko. Thanks, Desai.
Okay. Okay, thank you. Justin is trying to explain the dolphin. He says Garnedella vaginosis typically has a fishy smell and has an association with ectopic pregnancy due to damage caused to the fallopian tubes. Thank you, Justin.
Thank you.
Anonymous wants you to go to your YouTube channel, a slide. They just want to see, take a snapshot, and maybe then visit that
Yeah,
again.
sure. No problem, no problem, no problem, no problem, no problem.
Yeah. Ryan, whilst you are going there, we have
Yebo.
the chest X-ray masterclass coming through. Do you mind just to share one or two things? Why would someone want to attend that? I mean, the ECG masterclass was just superb, colleagues. I think those of you who attended both the first and second intake, you would have appreciated the effort, the approach, and the level of detail. That's why we call them master classes. The chest X-ray master class is coming back for the second time. I think we had one early around January. I might be wrong. Yeah, but yeah, Ryan, I don't know if you have two
Mhm.
words to say about the chest X-ray master class, as I share the link in the chat.
Yeah, no, absolutely, guys. Chest X-ray is one of the fundamental investigations we do in caring for patients. It's important for many kinds of presentations. Patients coming in with dyspnea, patients coming with chest pain.
Mm,
So I'm going to introduce you to X-rays, giving you a systematic overall approach to chest X-rays in general. And then we're going
mm,
to hone into specific views and look at specific pathologies and we could also, there's a beautiful quiz I got with about 15 real life examples. Okay, so just to put everything into context. So all in all, chest X-ray masterclass, an essential tool in your arsenal in taking care of patients. Yeah, strongly recommended, Leseko.
Thank you. Thank you. Thank you. Colleagues, let me try Mervin again. Mervin, are you able to say something so that I can test if your mic is working?
Can you hear me?
That's better. Thank you.
Oh,
Yebo, go
wonderful.
for it.
Hello there. What a wonderful presentation. I'm very impressed. I mean, I'm nearly 60. I graduated in 1989. And in 1991, I went to England and I specialized in HIV medicine because nothing was going on here. I came back a few years ago and I'm very distressed about the state of HIV medicine in this country. And I do my very best to help everyone. My thoughts are, are you interested in HIV medicine and its complexities? If not, it doesn't really matter. But, perhaps we can chat in the future and cooperate in terms of making sure that patients are well looked after, irrespective of the state system. I don't trust any of the private doctors. They're all full of shit. That's what I'm going to say. I think you're marvelous. You just present beautifully. And I think if everybody could learn from you, I would think that that would be a good thing.
Right.
Thank you so much. I really appreciate those very kind words.
No, I'm serious. I mean, I'm old now and I've worked all over the world, mainly in the UK, and your absolutely specific and appropriate approach to, things that are actually quite fundamentally simple is wonderful. So I do think it's very important that you continue educating people. There you go.
Thank you.
Yes, yes.
You need to talk to me soon.
Very soon. I saw your email on the
yes. I'm wasted here.
Hey, so where are you based, Mervin?
KZN, between KZN and Johannesburg, but mainly in KZN, and I go to the UK occasionally as well. But the point is, I can teach people. I can help people. I don't want money. I've never wanted money. It's about making sure that we can and your clinical care platform is amazing in this. And I followed you for several months, years. It's imperative that we keep educating and inspiring doctors to do better. Because nothing is not complex, as evidenced by, the talk. You might